Good afternoon, everybody. Tonight we are starting our residency lessons with the international invited speakers. Tonight's lesson will be done by Professor Vrublevska from Latvia, and she is going to talk about psychiatric interview and mental state assessment. Professor Vrublevska, the floor is yours.
Thank you. So I'm sharing the screen. Can you see my screen?
Yes, yes, excellent.
Great. Good afternoon, good evening, dear colleagues. Yes, I am Dr. Vrublevska, and I am adult psychiatrist. And before to start the seminar, I would like to say that Professor Vrublevska is a very important person in my professional life. He was an official reviewer of my doctoral thesis that was 4 or 5 years ago. And he is also our international mentor. Thanks to him, we participate in different very interesting international projects. So a couple of words about myself. I work in the capital of Latvia, in Riga, in the largest psychiatric center. And actually, this is a complex of different centers. So psychiatric settings are separated buildings. We are not a part of a general hospital. So now I am in my office, and this is the main clinic. Here is located 9 acute psychiatric wards, also outpatient center. And we also have 2 different large outpatient clinics in different regions of Riga city. So we will talk about psychiatric interview and mental state assessment. And actually, this is the basic tool. This good psychiatric interview is the basic tool of a psychiatrist. So this is our key skill, how to listen and talk to patients. And I remember years ago, Professor Sheehan told us, a good psychiatrist has to be a very careful listener and very careful observer. So, and therefore, this is the key skill, how to listen and talk to patients. And psychiatric interview forms the main part of psychiatric assessment, by which diagnoses are made. And it also actually is a part of psychotherapy, even if you are not a psychotherapist. The question is, how psychiatrists differ from other doctors? Well, today in the 21st century, modern medicine cannot be imagined without advanced technologies. In general medicine, it's very difficult to make precise diagnosis without some advanced techniques. But what about psychiatry? Our main tool is our skill to talk and to listen and also observe the patient. This is our main tool. How can we understand their psychopathology, make a diagnosis, establish treatment, and to make overall compliance with the patient? Psychiatric assessment has 3 important goals. First of all, to elicit the information needed to make a diagnosis, since the diagnosis provides the best available framework for making clinical decisions, the treatment, the management plan. Second, to understand the causes and the context of the disorder, to understand the origins of symptoms, how they unfolded over the time, how they progressed, and what is actually the further prognosis, and also to form a therapeutical relationship with the patient. Actually, one of the most important things that establish a good compliance of the patient to the treatment is a good therapeutic relationship. Concerning the basic psychiatric assessments, here you can see assessments in the general medical setting. So this includes history, and physical examination. But in psychiatry, things are a bit more complex. Here we can see that psychiatric assessment includes history, together with a mental state examination, and together with a physical examination. Very often, some physical signs can be administered and acknowledged by gathering careful history, evaluating patient's mental state, and also do some physical examination at the same time. Before the interview, what is important? First of all, the location. So it is also important to remember that we will discuss very intimate, very personal, and quite often distressing topics. Actually, patients tell to psychiatrists so sensitive issues that they never tell to their family members. Actually, sometimes in this term, we are even closer than their family members. And of course, this location, so the environment where this interview is held, is very important. Second issue is safety. So, and we know that acute psychotic patients can be violent, can be disturbed, they can be agitated, and our safety is the priority. So I say to my students or my residents, never go to the patient if you have concerns regarding your own safety. So, and how can we define whether the environment is safe? We can discuss this with a senior member of staff. Should you have somebody who accompanies you? So you also can check local procedures, maybe, for example, whether the panic buttons are working. In my office, I have panic button as well, but actually I use it extremely rarely. And those times when I use it, it's when the patient requires emergent hospitalization, even against will, but the patient is not willing to go to the hospital. And when I need some medical staff to accompany the patient to the hospital. So, of course, arrangement of seating also is very important. So, as we usually need to write, make medical records. So, in this case, also a table is absolutely fine to separate you with a patient. In psychotherapy, things are a bit different. So in psychotherapy, chairs can be arranged at 90 degrees to each other. So if it is a psychiatric assessment, so this can be a bit different way. Yeah? So it is very important to show that you as a doctor are relaxed, that you are confident, so, and you demonstrate this in your posture, in the way how you talk to a patient. Because, you know, when the patient feels that you are not fine, that you are stressed or embarrassed by something, yeah, so actually this somehow can destroy the trust to you in the patient. Information. So before the good psychiatric interview, available information is absolutely important if such exists, of course. Yeah? So these can be referral letters and previous notes. So, and these referrals provide a preliminary diagnostic hypothesis and clarify the reason for the referral. However, of course, not always these referrals are present. For example, today I had a patient who had the first contact with me. He never had any consultation with psychiatrists. So he is in the middle of his 60s with a quite severe depressive episode, with a complaint about cognitive decline, tremor in his hands, and he performed some laboratory testings before the consultations. He had MRI scans, so brain imaging, So also some medications were administered by neurologists, but he didn't bring anything to this consultation. So, and based on this, how can you manage quite successful and productive treatment if you don't know very important information? So it is also crucial every time to remind our patients, if you have any medical documents like your investigations, laboratories, or something else, please bring it with you and show it to me. Otherwise, it is very difficult to make correct clinical decisions. So before the interview, it is also important to approach the patient. It is a good practice to introduce yourself and also check the identity of the patient, and also to describe what you are going to do during this interview. And the confidentiality matter also is in high importance. So if the notes are taken, you have to explain why. Because if you take notes in front of the patient who is suspicious or who has some psychotic features like delusions of persecution, delusions of harm, so this process, when you make note, can be misinterpreted. And in this case, the patient can make some wrong assumptions about your further actions. So I had the cases when, for example, students make notes in front of the patient, and after the interview, patient involves those students in delusional beliefs, like they are trying to plot against him or spy on him or something else. So therefore, this question of notes is very important. When I talk to psychotic patients, especially if this is the my first contact with the patient, I try not to make any notes in order not to provoke any misunderstandings in this patient. So the next is the basic history. So we arranged our environment, we introduced ourselves, and important part of mental status assessment is the gathering very careful basic history. And what is included in this basic history? So important emphasis on the person's personality, so life experiences, also current circumstances. Actually, this background history is a crucial part of the psychiatric assessment, especially if these are first episode patients, when they appear in settings for the first time. And this very careful obtaining of basic history also actually enhance a therapeutic relationship. When you demonstrate that you really care, that you really want to know what has happened before the present moment. And of course, basic history is extremely helpful to identify causes and some precipitators for mental health problems. For example, childhood experiences, problems in relationships, some financial worries, different losses in life. So all this has to be assessed with a very, very careful approach. Basic history also reveal personal factors as that affect actually further management. So whether the presence of supportive partner is available, this could be important if some supervision of pharmacological regime is important. And also supportive partners are very important when patient is not really capable without advice and support maintain non-pharmacological issues like physical activities, regular and balanced food intake and other aspects. So how much this background information you should seek? of course, depends on the nature of the problems and also how well known the patient is for you. So this careful and very detailed approach is especially important when the patient arrives for the first time. And here are given some examples of the questions that can be asked to improve the gathering of this information. For example, I would like to ask about topics which are a bit more personal. Is that okay? This is a very nice approach how to open your patient, or acknowledge embarrassment. We know that patients can hesitate and even feel embarrassment talking about them when they talk about some very intimate or sensitive things. Yeah. So, and here you can encourage your patient by saying, I know these things are very difficult to talk about. And as the patient embarrassed talking about their pathologies, especially if they are aware about them, you can normalize these experiences by saying, some people feel like that in these conditions, as in give examples, how do they feel? And then ask, what about you? Have you had any problems like that? And this gives knowledge to the patient that actually he or she is not the only one who has these devastating and embarrassing symptoms. Of course, we also have to clarify the patient's age, marital status, occupation, living arrangements. So these living arrangements could be especially important for those patients if you have concerns about their wealth, about their financial stability, and even whether they have a living place. So we know that, for example, homeless people or those who live in extreme poverty are more prone to number of medical conditions, for example, tuberculosis, and this has to be assessed then, of course, for sure. So the next is presenting complaints and the history. So, and here you can start with the open questions. What do you think is the main problem? How have you been feeling? Actually, it is also fine to ask, tell me what are your main three problems. So here, the main three devastating problems. Here you will identify what is the most of all disturbing your patient. So closed questions also are very useful to clarify the responses. So for example, you say you are not sleeping well. Can you tell me a bit more about that? What time do you wake? So, and this will give you precise information. So encourage the patient to list their main problems and describe them in their own words. So apart this main problem, do you have anything else that disturbs you? And of course, this assessment of the nature, duration, and progression of each of these symptoms has to be done. So you have to clarify, are there any precipitating and relieving factors? For example, the person who has medically unexplained pains, you have to ask what maybe there are some stress or some worries in life that could be somehow related with increasing in these pains. Or maybe there are factors that when you feel fine, when nothing bothers you, you feel better and this pain is not so severe as it feels. It is also welcome to assess the degree of functional impairment. We know that we are actually social animals, and relationships, professional, in the family, with the friends and acquaintances, with the partners, are extremely important. And it is very important to know how and whether and how these symptoms actually affect relationships, how these symptoms affect daily functions like professional life or sleeping or entertainment or some other aspects of life. It is also advised to clarify whether this problem is seen to other people, whether this problem is visible to others. So, and how have others perceived these problems? So what did your friends say about you when you feel like that? Whether they can note it. So if the problems are visible to other people, it's more likely that these are quite severe problems. And of course, it is absolutely important to clarify treatments tried for the current problem. So, and these treatments should be assessed and asked not only pharmacological, but also non-pharmacological in detail. And we also have to clarify how actually they worked, whether they were efficient enough. So, and here is given some mnemonic, so notepad. So when you assess symptoms, when you assess history of symptoms, you have to clarify and define the nature of symptoms, if it's possible, onset, what triggers those symptoms, exacerbating and relieving factors, progression of these complaints over the time, maybe some associated symptoms exist as well, and finally, whether they cause disability, inability to function normally in daily life. So, and don't ignore medical symptoms. So in Latvia, psychiatrists quite often forget to assess medical symptoms carefully, but we have to remember that these patients have very high comorbidities of different medical disorders as well. So now we identified the history. So, and now about past psychiatric history. So whether the patient already have previous psychiatric contact. This can be a contact with a doctor in the outpatient setting or maybe in the hospital. So it is also should be clarified whether some diagnoses were given to the patient. Also, what kind of treatments were used for previous episodes of psychiatric illness, and what was the effect and side effect of this treatment. Also, self-harm and harm to others. So can be easily assessed with a question, have you ever harmed yourself or tried to kill yourself? So these questions can cause embarrassment in non-psychiatrists, in other medical professionals. We know if you ask about self-harm or suicidality issues in an empathic way, if you show your willingness to understand the patient, what is going on and what was his past, usually these patients are very actually opened and they really appreciate your desire to understand his or her mental condition and are quite opened. And we remember that we know that approximately 50% of psychiatry referrals have had a prior psychiatric contact. Not necessarily in your healthcare setting, it can be different city or even different country. So a previous diagnosis is important, but we need to remember that, however, it is hypothesis. At the moment, current diagnosis can differ from that was established previously, or some new diagnoses like comorbidities can appear. So therefore, past history may also provide useful information not only regarding the past psychiatric well-being, problems, functioning, diagnosis, but also provide useful information for further prognosis and also to the patient's attitude to their disorder. Family history is in extremely high importance. If there is a patient who is in your office for the first time, we have to start with the family. So ask the ages, occupations, and health of parents, siblings, and children if they are. So we know that majority of mental disorders can be genetically inherited, and questions about family actually gives us a lot of data. Also, quality of the family relationships has to be assessed. For example, by asking a question, how do you get on with your family? So because problems in family with the relationships to the other family members very often are associated with a current psychiatric disorder. So it is not something uncommon here when the patient is in the hospital and after 30 days is discharged and comes back to the previous environment. So with a problematic relationship, in the conflict situations, in this conflicting environment in general, this is a predisposing factor for a new exacerbation and a new hospitalization. So therefore, we have to work on this aspect as well. So also family psychiatric history, as I told you before, takes important role. So, and not only psychiatric history, but also medical history is in high importance. And any recent event in the family that probably could be associated with mental problems at the moment or in the past should be assessed as well. What about personal history and premorbid personality? So we always ask the questions about pregnancy, birth, and childhood. Not always patients are capable to give you that information. And in these cases, talk to a third-party persons like family members, so-called objective history is very helpful. We know that premature delivery or some not beneficial episodes during maternal pregnancy or traumatic delivery is an important risk factor for a majority of mental disorders. So also early childhood. So for example, neuroinfections during first year of life can play important role in the later development of mental disorders. So this has to be asked, and also early developmental issues like walking, talking at the right age, also the age when the patient was started reading, writing. So this also is important, and education. So at what age the person started school, how this patient was feeling in the school environment. Did he experience any bullying or other negative occasions in the school? At what age he finished? Whether he had any special education classes. So further educational progression is in high importance as well. So occupation and reasons for changes, military service, job satisfaction, whether the person was able to hold a stable job, so professional development, and of course also relationship. So number, duration, type, gender, whether the person was able to maintain close, intimate, stable relationship or not. So this ability to be in relationship actually is a very important indicator for some mental problems. personal history and premorbid personality concerning traumatic events. We know that exposure to suicide or self-harm in the past could be, and is a risk factor for some abnormal pathological symptomatology in the patient at the present. And of course, personality, premorbid personality, temperament is in the importance. So the patient's usual character, interests, habits. You know, not all patients are able to describe their own temper or character. So, and here you can give some clues to the patient by saying where are you sociable or you prefer to be a loner. So this will help to describe himself or herself better. So how would your friends describe you? How can you cope in a difficult situations? So, and also here we can ask the questions about religious, believe in God. We know that number of matters concerning religion are related with mental pathology as well. So in this slide are given few diagnostic clues. For example, conduct disorder can be a clue to the social personality disorder. We know that adverse childhood events are related with majority of mental disorders. Also, pattern of past relationship. For example, an absence of close relationship can be related to schizoid personality disorder or some F2 category diagnosis according to the ICD-10, or many intense emotional and turbulent relationships can be associated with the borderline personality disorders. And of course, the nature of employment and also relationships gives us understanding about a level of functioning in general. Social history. Yes, obtaining this history is also very, very crucial. So we want to know about current relationship, whether the patient has a partner at the moment. It is also fine to ask whether this is a partner of the opposite gender or the same gender. Also to clarify self-care and support. So by asking, for example, do you feel able to look after yourself at the moment? Who is there to support the patient and who is dependent on the patient? Also current employment and important current worries like financial strain or housing problems, relationship problems. So, and sometimes it is also worth to ask the patient to describe a typical day as well. So past medical history and also drug history. So you have to assess whether the patient already had some medical illnesses or surgeries, because medical illnesses can be highly related with ongoing psychiatric condition as well. Also current medication and adherence. So which medications patient takes at the moment, do they give any side effect? And actually we have to make a list of all medication that the patient takes at the moment. Remember one of very famous Professor Funtulaki's slide that he demonstrated in one of the congresses about his patient who took more than 20 different pills. Of course, these medications can interact between themselves and interfere with the psychiatric condition. And moreover, we also have to think how these medications will interact with our drugs that we will prescribe. Also, some complementary and alternative therapies that are used by the patients. Our patients quite often can use some herbal therapies, and we know that herbal therapies also can be very active interactors with the CNS agents, or or they can use something else. Yeah? So, and finally, also allergies have to be clarified whether such exists or not. So this medical history is important part of mental state assessment because it overlaps with psychiatric disorders as well. So, and finally, we also come to the basic mental state examination and what aspects of should be evaluated. First of all, this is appearance and behavior. And actually, this one is quite often underestimated source of diagnostic information. Sometimes we can have patients who are totally mute. They do not talk to you at all because of they, for example, delusional beliefs, or maybe hallucinations, auditory voices do not allow talk to you. And in this case, if you are a very careful observer, you can identify psychotic disorders just by evaluating appearance and behavior of the patient. Second is speech, mood, thoughts. And in this section, you have to assess whether there are some disturbances in thought form, for example, disturbances in thought flow or continuity of thoughts, and also identify whether there are some disturbances in thought content, for example, overvalued ideas or delusional ideas. So, perceptions, and in this section, we have to identify and very carefully describe any perception abnormalities, if illusions exist or hallucinations exist, and this part has to be described in every small detail. Cognition, cognitive functioning, and impairment that can be characteristic of dementia, delirium, but also characteristic of some other mental disorders, such as depression, for example, or schizophrenia. We know that these conditions are accompanied with a cognitive decline. And finally, also insight. So you can be very modern in prescribing medications to your patient according to the guidelines. But if your patient has poor insight, your efforts to treat current illness will not be efficacious. That's why insight is absolutely important part to assess and to describe. So in Latvia, we describe mental state in a comprehensive narrative form. In other words, we write a comprehensive story, including in detail every part of what has to be examined. And actually, what is a good description of mental state examination? It is when a person who never saw this patient, who is not aware of the pathology of this patient, while reading your work, can imagine appearance, pathology, behaviors, when the clinical picture is absolutely clear. So, and now let's focus more detail to all these aspects. First of all, appearance and behavior. Of course, we assess the level of consciousness and whether the person is alert or maybe sleepy. So appearance, dress, posture, hygiene, also apparent body mass, all these things that you can see, you can detect, should be described in details, all abnormalities. Maybe the person uses too excessive makeup or uses too many accessories. This, in some cultures, could be a pathology that has to be described. Of course, when we assess mental status of the patient, we have to do it with respect to the current culture and current religion of the patient, because what is norm in one culture can be some abnormality in other ones. So we have to be really educated in various aspects. So body language and movement. So overactivity, abnormal movements, some changes in gait, also some behaviors that actually can represent hallucinations. So objective signs of hallucinations, in other words. So also eye contact and a rapport with the interviewer. So whether the patient is open, maintains the eye contact with you very well, or is defensive, evasive. Speech. So quantity and spontaneity of the speech, whether the patient speaks spontaneously, whether the patient is active in conversation for you, or maybe patient express poverty of speech, is not talkative. Maybe patient is giving only information that you ask in few words, in one word. Alogia, for example, maybe information that the patient gives you is absolutely insufficient, and you have to ask questions and again to obtain some basic information. Also, volume rate is in high importance. So pressure of speech, for example, which is a typical, for example, to patients who have mania. So when the patients are talking very rapidly in monologue, and you have to interrupt the patient, otherwise this never stops. Or maybe the speech is slowed, which can be a sign of slow and retarded thinking. So in depressed patients. Tone, so the emotional quality of speech, angry, sarcastic, or maybe speech is absolutely monotone without any changes. Articulation, so is the patient's speech hard to understand? And this can be dysarthria, for example, slurred, strangled speech, which can be a sign of various neurological conditions, or maybe side effect of antipsychotic drugs, or maybe changes in the content, like dysphasia, for example. Mood, subjective mood. So this is a self-reported mood. And here are given tips how to ask the patient about his or her mood. And it is also advisable, if the patient complains about decreased mood, to ask about how low it is on a scale of 1 to 10. So this will give you some signs how decreased mood is. So objective mood, which record how the patient mood appears to you. And this may be different from subjective mood. And here you can describe the mood itself, what you see. So elevated or depressed or unremarkable, its constancy. So flat, labile or reactive, and also its congruity, whether it is congruous or incongruous to the current situation. So constancy describes how the mood shifts over the conversation, and this is not really normal if the mood during your interview doesn't change at all, because usually we are asking about different aspects of patient life. A labile mood shows marked fluctuations, and incongruity describes how well the patient's mood fits with what they are thinking or perceiving. So, and sometimes we can see that, so there are absolutely opposite things when mood is absolutely incongruous of what the patient tells you. For example, about some tragic and dramatic life events, smiling and even joking and laughing. thoughts. So, and we know that thinking disturbances can be classified as disturbances in thought form or flow. So, and in this case, it will be rather difficult to follow what the patient tells you. So, and the second is content. And here we have to assess whether the patient has overvalued ideas, or maybe the patient has delusional ideas. Delusional ideas are absolutely totally fixed, false beliefs that are not consonant with the patient's education and religion and cultural background. And we need to know that what can be a delusion in one culture can be a norm in another culture. So we have to respect different cultures, religions, ethnicities. So, and clarifying overvalued ideas or delusional ideas, we can ask the question, do you feel that people are plotting against you or are trying to harm you in some way? Worries and obsessions. So we know that obsessions are repetitive thoughts, really disturbing and distressing thoughts. And it is important to remember that obsessions are patients' own thoughts. They must not be inserted in the patient's mind from the outside. Patients can be very critical to obsessions thoughts. They arise extreme anxiety. And therefore, if you detect that these obsessions exist, in this section, you also have to ask about compulsions. Of course, this is not thought disturbance, but it is useful to ask about it. So, because we know that as the response to obsessions, patients can perform some repetitive behaviors or rituals in order to get rid of these obsessions. Also, questions concerning possible phobias should be asked, and of course also suicidal ideation and morbid thoughts as well, like do you have thought of harming yourself or to the others, morbid thoughts about maybe you have thoughts about having some severe medical disorder that is uncurable. Perceptions. In this section, you identify whether some illusions or hallucinations are present. And if the patient has these disturbances, it is important to ask about them in every detail. For example, if the patient hears the voices, first of all, we have to ask where these voices come from. Are they sound within patient's head or in some other part of the body, or they are somewhere around in the room, or maybe they come from huge distance, for example. So the second issue, you have to ask how many thoughts, how many voices are there, and what they are actually telling to the patient. These thoughts can be very pleasant. These voices can be pleasant to the patient. If the voice tells that you are the most beautiful woman in the world, or you are a goddess of the beauty, this gives a pleasure. Or maybe these voices are giving running commentary, which is very annoying, or give commands or even threatens. So, and if delusions or hallucinations are detected, it is important to clarify how these psychotic features affect patient's behavior. Because if the patient's behavior is at somehow risk to self or others, of course, this is an indication to the hospitalization. And derealization and possible depersonalization also has to be assessed. Cognition. So here you can have to ask about orientation, so time, person, place, level of consciousness. So consciousness is normal, or maybe consciousness is clouded. So you also have to assess memory, especially in elderly patients, immediate recall, short-term memory, also long-term memory. We know that cognitive impairment is the hallmark of dementia. Delirium, however, it is a feature of other mental disorders as well, in case of depression, so-called pseudo-dementia, or maybe in schizophrenia as a cognitive decline. In delirium, of course, it is a state of clouding consciousness. If you have concerns about possible dementia or maybe intellectual decline, intellectual retardation, you have to assess calculations of the patient, general fund of knowledge as well, and also abstract reasoning. So how do we assess abstract reasoning? So it describes the ability to mentally shift back and forth between general concepts and also specific examples, ability to come to conclusions, to use jokes, to understand humor, metaphors, and aphorisms. And actually, you can easily ask to explain some metaphor or aphorism, and this way you can assess this aspect. And finally, also insight. So insight is not all or nothing, but a matter of degree, and it fluctuates according to the mental state. So whether the patient is aware that he or she is ill, so that something is wrong, and what exactly is wrong. Whether do you think that your voices are real, or this is a part of illness? Do you need a treatment? So, and insight quite often in real life conditions is a partial or formal, and this is not something uncommon when the patient who has exacerbation of schizophrenia arrives to admission department of psychiatric hospital and asks to hospitalize, but at the same time completely denies that existing voices or bodily perceptions or delusional ideas is a part of illness. As we psychiatrists say, even walls in our hospitals are healing. So patients feel safe and secure here. So when a physical examination is necessary, so the physical examination is important because we know that medical conditions are very commonly present with psychological symptoms. And our patients, especially with a severe mental illness, with a chronic course, they are neglecting their physical health. They do not attend the general practitioner. They do not perform regular investigations, and their physical examination is poor. And it is up to a psychiatrist to follow physical condition and physical health as well. And when there are some alarming issues, we have to organize also consultation with other specialists in this case. So, and when physical examination is necessary, first of all, in the setting. So every hospitalization also requires physical examination as well. If the patient is mentally stable, but haven't been seen by a doctor quite a long time, this is another indication for physical examination. Homeless people, we know tuberculosis and other risk is quite high, and also disorder and its treatment. For example, alcohol misuse quite often is accompanied with various physical problems, neurological problems. So I would like to say just a bit about assessing suicidal ideation. And I included this assessment separately and would like to emphasize it because this is something very important. And every psychiatrist has such experience when the patient not only tried to commit suicide, but even finished it. And it is related with the really unpleasant experiences and feelings in ourselves, first of all. Yes, and not all patients had these visible signs of suicidal risk. And therefore, we always have to assess suicidal ideation with the real carefulness. So, and risk factors could be so-called sad persons, pneumotic, sex. So women are more likely to attempt suicide. We know that men are more likely to succeed. So also it is related with age, depression, previous attempt, ethanol use and abuse, rational thinking loss, lack of social support, organized plan. So when a well-formulated suicide plan is a red flag for us. No spouse, so loneliness, in other words, and also sickness. Chronic illness is a risk factor. And short-term warning signs of suicidal behavior include reckless, feeling trapped, increased substance use, withdrawal, anxiety, insomnia, mood change, lack of purpose for or a reason for living. So if these signs are present in your patient, so it is beneficial to assess suicide risk as well. So, and the case approach is recommended, started by assessing the presenting suicidal ideations or event. So elicit information about any suicidal ideations over the past 2 months, explore positive ideations, and return to the present and explore any immediate suicidality. So the rationale here that the process of exploring the presenting event and the past allows you to establish rapport with your patient as well. And as if we do it in an empathic way, if we show our compassion, this also very nicely improves the alliance with the patient. So concerning strategies, so we can ask in general questions. So do you feel like you are tired from life? Or maybe you have a feeling that you do not want to wake up. Maybe you had any thoughts of wanting to hurt yourself. So, and not necessarily if patients have such thoughts or have had such thoughts, they have real plans. But definitely, if the patient has answered these questions with a yes, you have to ask more detailed and specific questions. So have you thought about cutting yourself, taking an overdose, jumping from the window, shooting yourself? Yes, if the patient answers with yes to this, we go further to clarify these thoughts in more detail. So have you planned it on your mind? So, or maybe you acquired any of these things, you would need to do something. Have you actually had the pills in your hands? So we assess specific issues. Maybe the person tried but not finalized these questions. So, and these are questions to those who might have some plans. Yeah? So we ask whether the patient is ready to commit it and has the equipment to do it. So in some practices, doctors prefer to make some specific, forgot this English word, contract with the patient. If you have very strong ideation, you have to call to this or that person, or you can call me. So, but these contracts are not always efficient. Not all doctors are perform it, and it could be quite risky, I would say. So if the person has a very strong ideation, so this is an indication for hospitalizing the patient. So we are running out of time. So, and one thing, the last thing that I would like to emphasize are the special problems in interviewing the patients. So psychotic patients, we know that they have thinking problems. They also can have cognitive problems, and therefore interview with them should be focused and structured. So open-ended questions and long periods of silence could really disorganize them. Short questions are much better. So, and questions calling for abstract responses also are not good options for these patients. So another issue is that we never agree with psychotic features of these patients. We never support and never say, yes, you are right, if the patient has delusional ideas. We show our understanding. We want to clarify how these delusions develop, but we never agree with these delusional ideas. Otherwise, we maintain the illness. In case of depressed patients, severely depressed patients may also have difficulties in concentrating, thinking clearly, speaking spontaneously. Actually, they are not informative at all. So we always have to assess whether some psychotic symptoms are present, for example, delusions of guilt. And all depressed patients must be asked about suicidal thoughts in detail. And also finally, agitated and potentially violent patients. So those who are at risk to have or already have psychomotor agitation. So, and here the interview should be conducted in a quiet, non-stimulating environment. So there should be enough space for the comfort of the patient and of course for psychiatrists as well. And during the interview, psychiatrists should avoid any behavior that could provoke some violent behaviors, like standing over the patient, or steering, or even touching the patient. This is not advisable. And when we assess these category of patients, first of all, we have to think about our safety and secure, first of all. Ending the interview, so summarize what you have been told back to the patient. So, and this helps ensure that you obtain the correct picture and that you understand what is the problem of the patient. So give the patient an opportunity to ask the questions, and also, of course, detailed explanation what you plan to do next is important. And these horizontal relationship, alliance with the patient, when you together with the patient decide together the best management for current person. So, and key points from the mental state assessment. The aim of psychiatric assessment is to gather sufficient information to make a diagnosis and set it in a context. Most information comes from the history and mental state. Examination, however, physical examination has not been ignored as well. Diagnostic hypothesis should be made early in the assessment and then tested using more specific questions. So psychiatric disorder can and should be rapidly screened in all medical settings, and our interviewing skills allow us to gather information efficiently and form effective alliance in the patient, and also maintain good relationship in the future as well. Here, I would like to stop and say you thank you for your attention.